Welcome to Early Age Onset Colorectal Cancer Updates session, understanding the latest science and practice to inform care across the continuum. We have a wonderful panel today, and very happy to introduce all of them to you, and then I'm sure that we'll learn a lot. We'll start with Caitlin Murphy. As you know, she's an associate professor at the University of UTHealth Houston, and she's worked extensively on the epidemiology of early onset colorectal cancer. And I think she'll tell us hopefully more than what we know, which is that there are all these risk factors that we've known for a long time associated with colorectal cancer in general that have also been associated with early onset, but there are still gaps that we have because they just don't seem to add up, all these risk factors. But so environmental exposures maybe in utero and all these early in life could give us some hints on the explanation for that, and we're looking forward to hear from Caitlin what her thoughts are about her research on that. Then we'll move on to an experience by the University of Virginia. Tala Mahmood will tell us about it. She's a third-year resident who we want to make sure that she continues engaged in these groups, so please consider that. And she's going to address the lead time, and she'll do that explaining us about this project that they've done. They're working with the medical community on that, which, as we know, is important. And finally, Nancy Yu from the MD Anderson will give us some updates on the treatments for colorectal cancer. We've gone far with the all the treatments, and the life expectancy really has improved considerably. She'll go through all these, and I think we'll learn quite a bit. So I think it's going to be a great session, and we'll keep the questions for the end, maybe. Yeah, we'll keep the questions for the end. And again, welcome to the session. I'm sure we'll enjoy it.
Okay, well, good morning, and thank you all for the opportunity to give an overview and summarize all that we've learned about the epidemiology of early onset colorectal cancer. These are my financial disclosures. I don't think it's a secret to anyone here that incidence rates of colorectal cancer are increasing among younger adults or people under the age of 50. In this figure, I've plotted the incidence rate of early onset colorectal cancer in the United States. And even though the rate is much lower than what we see among older adults, we can see a very clear pattern of increasing incidence rates since the early 1990s. There are many questions about why incidence rates of early onset colorectal cancer are increasing. And in 2017, the Roundtable convened a small group of researchers to identify unanswered research questions, which I've listed here. We've since made some really important progress in providing answers to these questions. And today, my goal is to summarize this progress by providing recent data and studies that are relevant. I'll move pretty quickly and spend just about 3 minutes on each question, and I've picked these 6 questions because I think they provide guidance for where we should go next. The first unanswered question in 2017 was, what is the role of known risk factors? The answer, as we now know it, is that well-established risk factors like obesity and diet also increase the risk of early onset colorectal cancer. In other words, the risk factors for early onset colorectal cancer are more or less the same as risk factors for colorectal cancer in older adults. We learned this from a 2021 study that I've pictured here, and that pooled 13 population-based cohorts to identify a range of risk factors associated with early onset colorectal cancer. In this study, there were near identical associations between dietary risk factors and early compared to later onset colorectal cancer. I've listed the odds ratios in the table at the top of the slide for associations with dietary risk factors like folate, red meat, and fiber. And again, you can see the odds ratios for early and later onset colorectal cancer are nearly identical. There are also near identical associations with lifestyle-related risk factors, including cigarette smoking, sedentary lifestyle, and higher alcohol use. You can see that illustrated in the figure at the bottom of this slide. Here I've put the odds ratios along the y-axis and the association for early onset colorectal cancer in orange and later onset colorectal cancer in blue. We've observed the same phenomenon on the other side of the world in South Korea. I've included here a population-based study of more than 9 million adults receiving care under a national health plan over a 10-year period. The goal of this study was to identify components of metabolic syndrome associated with early onset colorectal cancer. And sure enough, there's a similar association between metabolic syndrome, which is defined here as having at least 3 of 5 components, and early and later onset colorectal cancer. You can see in the table at the top of the slide that the hazard ratios are both about 1.2. There was also a similar association between the number of components of metabolic syndrome. You can see in that figure at the bottom of the slide that the risk of both early and later onset colorectal cancer increased as the number of components of metabolic syndrome also increased. The second unanswered question in 2017 was about whether risk factors differ by tumor site or whether there are different risk factors for colon versus rectal cancer. Although there's still certainly more we can learn about this question, my answer today is sometimes yes and sometimes no. The motivation for asking this question was based on the observation that rates of rectal cancer have really driven the overall increase in early onset colorectal cancer. We can see this very clearly in the data. In this figure here, I've plotted incidence rates of early onset colorectal cancer by tumor site over time since the early 1990s. The numbers get a little bumpy because we're looking at smaller groups, and so I'll point out 3 observations. First, we can see that the rates of proximal colon cancer, which are shown in the gray color, have remained pretty flat over time. Second, and compared to proximal colon cancer, there have been more prominent increases in rates of distal colon cancer, which is shown in the blue color. And then third, the rates of rectal cancer, shown in that orange color, have increased rapidly over time, such that they are now the highest among all tumor sites. This figure shows the same exact data, but just in a slightly different way. I've simply smoothed over the estimates by comparing the rates in 2 different time periods. We see a pretty similar pattern. There's been a striking increase in the rates of early onset rectal cancer, and to a somewhat lesser extent, an increase in the rates of distal colon cancer. Based on these data, we've done a somewhat decent job of identifying risk factors for colon and rectal cancer. And I'll return to this 2021 study that I showed you earlier and that pooled the 13 population-based cohorts. This study also reported a similar risk of early onset colon and early onset rectal cancer associated with known risk factors like cigarette smoking, sedentary lifestyle, and some dietary risk factors. You can see those odds ratios in the table at the top of the slide for, again, the associations with colon and rectal cancer. In this same study, there was also some suggestion of differential associations, and I've listed those risk factors at the bottom of the slide. For example, lower fiber and lower calcium intake appeared to be more strongly associated with early onset rectal compared to colon cancer. The third question that we asked in 2017 was, what is the role of proposed or novel risk factors, or are there risk factors for colorectal cancer that we previously haven't thought possible? The jury is still out on which among thousands of possibilities are the most important novel risk factors, but what we've learned so far, I think, is that the environment is a top suspect. There are likely risk factors for both early and later onset colorectal cancer related to environmental chemicals or toxins. Now, I understand that we rarely talk about environmental chemicals as risk factors for colorectal cancer, but we're starting to see some signals that these may be important. As an example, I've included a 2023 study here that was conducted in Sweden and examined the association between disinfection byproducts in drinking water and colorectal cancer at any age not specific to early onset colorectal cancer. For those that may not be as familiar, disinfection byproducts are substances that are formed when chlorine or other disinfectants react with organic compounds in drinking water, and some of these substances have induced large intestine cancers in rodent models. In this study, drinking water treatment plants were mapped to residential address for participants of 2 large cohorts, and participants were followed prospectively for colorectal cancer ascertained through a national cancer registry. Compared with no exposure, both low and high exposure to disinfection byproducts was associated with colorectal cancer in men, but not women. You can see in the table at the bottom of the slide that the hazard ratios for the associations among men are about 1.25. As an additional example, I've included a study here that examined the association between colorectal cancer, again at any age, and polychlorinated biphenyls or PCBs. PCBs are a family of industrial chemicals once used in electrical equipment and as plasticizers in paint, plastics, and rubber products, and they've been linked to numerous adverse health outcomes in humans, including some cancers. Now, this is an older study that was conducted among a much smaller sample in Spain, but I still think it provides us with some compelling evidence that the environment is a top suspect. Here, PCBs were measured in serum collected from cases or patients newly diagnosed with colorectal cancer and controls or patients in the hospital for some other reason. You can see in the figure at the top of the slide that serum concentrations of several PCBs were higher in cases, who are shown in the orange color, compared to controls, shown in the blue color, including PCB 28, 118, and 153. In this same study, we also see that high exposure to PCBs was linked to KRAS and TP53 mutations in tumors. As you can see at the table at the bottom of the slide, PCB28 was associated with colorectal cancer regardless of mutation status, but PCB118 seems to be more strongly associated with TP53 mutated tumors. Importantly, even though PCBs were banned from manufacturing in the United States in 1979, they persist in our environment and can be detected in the blood of nearly all people. The fourth question that we asked in 2017 was whether there are vulnerable times of exposure related to risk, or if exposure at certain times across the life course confers a greater risk of early onset colorectal cancer. The answer is yes. Exposures in early life, beginning as early as gestation or in utero, may set the stage for colorectal cancer diagnosed many decades later in adulthood. The motivation for asking this question was based on the observation that rates of early onset colorectal cancer have increased by birth cohort. In this figure, I've plotted incidence rate ratios across birth cohorts, which you can see along the x-axis, and each point on the line compares the rate for a particular birth cohort to the rate for the 1955 to 59 birth cohort. We can see that rates remained relatively flat for the silent generation and early baby boomers, or persons born before about 1960. There were then gradual increases for persons born through about 1980, followed by sharp increases for millennials, and so much so that the relative rate is now higher than it has been for any other birth cohort that we've been able to measure with available data. A birth cohort effect like this is meaningful because it tells us that exposures in early life may be important risk factors. For example, there were several pregnancy-related exposures introduced in the 1960s, ranging from environmental chemicals to certain medications prescribed during pregnancy, and that may contribute to higher rates of colorectal cancer among offspring exposed in their early life. As an example, I've included a study here that I was lucky to work on with the Child Health and Development Studies. The Child Health and Development Studies is a multi-generational cohort of nearly all pregnant women receiving prenatal care in the Kaiser Health System in Oakland, California between 1959 and 1967. Very detailed clinical information was collected prospectively from mothers' medical records, including all diagnoses and medications prescribed during pregnancy. These data have been linked with the California Cancer Registry to ascertain colorectal cancers in adult offspring and for a period of follow-up that extends more than 60 years after they were born. Here we examined in utero exposure to bendectin, which is an antiemetic commonly prescribed to pregnant women in the 1960s to treat morning sickness. You can see from the figure at the bottom of the slide that the cumulative incidence or risk of colorectal cancer was about 3 times higher in offspring who are exposed to bendectin, shown in the orange color, compared to offspring who are not exposed. A fifth unanswered question in 2017 was whether early onset colorectal cancer is molecularly different than colorectal cancer diagnosed in older adults. I personally was very convinced at the time that colorectal cancer in young people was a different disease than anything that we had seen before. But today, I'm more convinced that there really aren't that many differences. We've learned that early onset colorectal cancer looks somewhat similar to colorectal cancer diagnosed in older adults. We can see this very clearly in a 2021 study that I've pictured here, and that conducted comprehensive genomic analyses of colorectal cancer diagnosed in 3 age groups: 14 to 35, 36 to 49, and 50 and older. As you can see in that figure at the top of the slide, there were essentially no differences in the frequency of oncogenic alterations between early and later onset colorectal cancer. There were some small differences in the frequency of TP53 and KRAS mutations, but these differences were not statistically significant after adjusting for tumor site. Similarly, there were no differences in tumor mutational burden, fraction of the genome altered, whole genome duplication, or loss of heterozygosity by age. As an additional example, I've included here a 2019 study that compared the frequency of oncogenic alterations by age less than 40 and age greater than 50. We do see some differences, which you can see in the figure at the top of the slide, for the frequency of TP53, APC, and KRAS mutations by age, but these differences are somewhat small and are the only differences among a total of 403 genes tested. I do also want to mention that in this study, when age was modeled as a continuous variable, there were certain mutations that increased with increasing age and others that decreased with increasing age. To me, this says we should probably think about colorectal cancer across a continuum of age and not necessarily as early versus later onset. So finally, the last unanswered question from 2017 was, what are best practices for identifying and managing early onset colorectal cancer? I want to focus my answer today on this question to what we've learned about the importance of acting upon family history and minimizing time from symptoms to diagnosis. In the 2020 study that I've included here, we can very clearly see the impact of implementing guidelines for screening based on family history. There have been guidelines for earlier screening based on family history for many years, generally beginning at age 40 or 10 years prior to the age that a first-degree relative was diagnosed. Here, there were about 2,500 patients diagnosed with early onset colorectal cancer between the ages of 40 and 49, and who were identified from the Colon Cancer Family Registry. About 1 in 4, or 25% of these patients, met criteria for earlier screening based on family history, and about half of these because they had a first-degree relative diagnosed before the age of 60. Importantly, if we consider only those who did meet the criteria for earlier screening, the guidelines would have recommended initiating screening at the same or an older age than the age that they were diagnosed for only 2%. And instead, the vast majority, or 98%, would have been recommended to initiate screening at a younger age than the age that they were diagnosed. Simply put, almost all of these cancers could have been diagnosed earlier or even prevented if screening had been implemented according to family history guidelines. So next, this is a study that was published earlier this year, and we can really see the impact of symptoms on timely diagnosis of early onset colorectal cancer. We've heard repeatedly from patients that they experience symptoms before their diagnosis and that were often ignored by the healthcare system. In this systematic review of 81 studies, we've learned for the first time just how common these symptoms are. You can see in the figure at the top of the slide that patients frequently present with symptoms such as hematochezia or blood in stool, abdominal pain, altered bowel habits, weight loss, and diarrhea. Importantly, these same symptoms are associated with risk or early onset colorectal cancer in the general population. The table at the bottom of this slide shows the effect sizes for hematochezia taken from the same systematic review. You can see that persons experiencing hematochezia have anywhere from 5 times to 54 times the risk of early onset colorectal cancer, really emphasizing the importance of timely follow-up of symptoms. So we started today talking about the 2017 unanswered questions that the roundtable identified, and I hope that I've provided some answers to these questions so that we can push the research agenda forward and decide where to go next. I think it's time to move beyond studies of known risk factors and comparisons by the somewhat arbitrary cutoff of age 50. Instead, I'd really like us to refocus our efforts on identifying risk factors for rectal cancer, and we should be conducting innovative studies of environmental exposures. I'd also like us to identify opportunities for measuring exposures across the life course and not simply in the few years before diagnosis. There is clearly a need to implement evidence-based interventions, many of which already exist, to act upon family history and initiate earlier screening. Finally, I think there may also be opportunity to test non-invasive strategies for triaging patients with symptoms, much like they do in the UK, to really improve the timeliness of diagnosis. Thanks very much for your time, and I look forward to questions at the end of the session.
Good morning, everyone. I'm thrilled to be joining you today to share some information on the campaign that we held earlier this year during the month of March at the University of Virginia, spreading awareness on early onset colorectal cancer. Today, I'm hoping to give you a brief overview of what our campaign looked like, how we executed it, and what the results we saw. So to give a little bit of background, inspired by the NCCRT Lead Time Messaging Guidebook, we realized that by 2030, 1 in 10 Americans aged 20 to 49 will be diagnosed with colorectal cancer. It is now unfortunately considered a leading killer in young adults, and then the rates have been on the rise since the 1980s and unfortunately will continue to uptrend. That, coupled with our own personal connection with the cause, really inspired us to pursue this initiative. I myself have had multiple family members over the past decade get diagnosed with colorectal cancer, 2 of which were under the age of 40. So what was our initiative like? We really wanted to focus on raising awareness on early onset colorectal cancer among not only young adults, but young healthcare professionals as well. Really educate them about the symptoms and the importance of taking action early on. During medical school, we get taught the importance of colorectal cancer, but it's mainly focused on the elderly population, so it's not something that's ingrained into our teaching. And we wanted to change that narrative. We focused on individuals between the ages of 18 and 35, a demographic that we felt is traditionally overlooked in traditional efforts. And then the guidebook did show that young adults really desire that information from their healthcare providers. It was a collaborative approach because we were targeting young adults and young healthcare professionals. We really wanted them to be part of our campaign. And so we brought together diverse members of the UVA community, including undergraduate students, medical students, internal medicine residents such as myself, GI fellows, and faculty members. Hidden Cancer Below the Belt was an incredible collaborator as well. If you're not familiar with them, they're a nonprofit that is based in Richmond, Virginia, and their mission is to spread awareness on early onset colorectal cancer and increase access to screening methods. And shout out to Mindy, who unfortunately was not able to join us today, who is the founder of Hidden Cancer Below the Belt. And so I know I spoke a lot about the guidebook, and so I thought I would dive in and share some messages that resonated with us. During this part, so what happened is the NCCRT shared some messages with individuals and asked them what comes to mind when you hear this message. The first message was, did you know that colorectal cancer is expected to be a leading cause of cancer-related deaths among individuals between the ages of 20 and 49? And what resonated with people is that it really illustrates that you're never too young to get colorectal cancer, unfortunately. The second message highlighted that colorectal cancer is on the rise among young adults and among those who are unfortunately considered too young to begin screening, and people often experience symptoms for several months before being diagnosed. And what resonated with people is that it stands out because it's a silent killer, and this does apply to the younger generation who are traditionally not thought of as individuals who are at risk and are often overlooked. The guidebook also shared some ways you can help tailor your messages based on the age group that you are targeting. And so for individuals between the ages of 20 to 29, this group usually believes that it's important to get screened on time. It's really important for them to have a trustworthy relationship with their medical providers, and then they use YouTube and TikTok as their top social media platforms. And so ways we can tailor messages to them is really focus on symptoms related to CRC and really encourage them to know about their family history, because that's an incredibly important topic. And for people between the ages of 30 to 39, this group unfortunately is less likely to bring up screening, and they use Instagram as their top social media platform. And so ways we can help tailor messages to them is to obviously recommend the regular screening age, which is 45, and mention to them who needs to be screened before that. And of course, if they're experiencing symptoms. And because we were targeting young healthcare trainees, I thought I'd shed some spotlight on some of the additional recommendations that were in the guidebook, which is young people are unfortunately less likely to discuss colorectal cancer screening in general with their healthcare providers, including their family history. We as clinicians should routinely use family history to help us figure out who is at a higher risk of getting colorectal cancer. And then obviously promoting primary prevention and early detection to help reduce mortality overall. And then we should always keep colorectal cancer in the back of our minds as a potential diagnosis, and not just anchor on the fact that they are too young to get this. And this is especially important for females as well, because a lot of the GI symptoms, unfortunately, overlap with gynecological symptoms, and so it's much easier to dismiss. And so how did we go about doing our campaign? We started talking about the campaign in August of 2023, and we held multiple meetings with undergraduates, medical students, residents. We really wanted to brainstorm ideas of how we can help tailor our messages best. Between the months of December and February is when we focused on content creation, so our infographics and whatnot. And then March is when we launched our campaign. Now, what did our campaign look like? It was divided into what I like to call two sub-campaigns. We had our media campaign and our on-grounds campaign, both of which were happening at the same time. For our media campaign, we had our social media infographics as well as our local radio station opportunity, which I will get to. For our social media campaign, we used Instagram as our top platform. We utilized several pages, including the UVA GI Fellowship webpage, the UVA Internal Medicine Residency page, and the Hidden Cancer Below the Belt page. We also shared our infographics with the UVA Cancer Center, which really liked the infographics and decided to share them on Facebook as well. So I've spoken a lot about infographics, and so what did they actually look like? We tried to keep the design simple and colorful with catchy titles. So, too young for this, it's not just an older person's disease, really highlighting that this is something everyone should think about. And then you're pooping you, so what should you look for in your stool to figure out whether or not you need to talk to someone about that? Booty camp, so signs and symptoms that should make you worry about colorectal cancer. And some risk factors that could potentially increase your risk of colorectal cancer. And then love your gut, protect your butt. 6 ways you can reduce your risk of colorectal cancer. So really reinforcing the need to stay active, limiting alcohol, not smoking, limiting processed and red meat. And then obviously emphasize that everyone at age 45 should be getting screened. And then certain individuals who either have a family history, specific genetic syndromes, have a history of IBD, all of which should get screened earlier than 45. And I know not everyone is a fan of colonoscopies, and so we wanted people to know that there are alternatives, which are the stool-based tests, to really encourage screening. In terms of the radio segment, I had the opportunity to join a local radio station to talk about our campaign in general, as well as highlight early onset colorectal cancer. And then our On Grounds campaign, which was happening at the same time, ran over the span of a week. And we had different events happening on different days, which I will get to. And on our flyer, we also had a Did You Know segment that highlighted random facts about colorectal cancer, such as 1 in 5 colorectal cancer patients are diagnosed between the ages of 20 and 54, and that early onset colorectal cancer has unfortunately doubled since the 1990s. So on one day, we had an amazing guest lecturer, which is Dr. Priyantha Kant, who is the director of GI cancer prevention at Georgetown, who came and gave an amazing lecture to our medical students, residents, and fellows, and it was highly attended. And then we had our inflatable colon day, which we had a 10-foot colon in the hospital cafeteria, which attracted a lot of attention from people. We had medical students, staff members, patients, all come and learn more about colon cancer in general. Hidden Cancer Below the Belt had a booth right nearby that also helped us with spreading the message. In this picture, this is actually the entirety of the first year medical student class. So a lot of people really, really liked it. And then we had a Wear Blue Day, whereby we encouraged our fellows and staff to wear blue to really highlight colorectal cancer. And then our campaign was also featured in the medical school newsletter, which really helped deliver our message and broaden it even further. And so what were the results that we saw? Our campaign, in terms of the Instagram data, this is only pulled from the UVA GI Fellowship page, so that does not include the internal medicine residency nor Hidden Cancer Below the Belt data. But we reached a total of 1,100 accounts during that week. We had 444 new profile visits and 63 new followers. And then in terms of the listenership for the radio, this was mainly a guesstimate because I couldn't get this number, but per the internet, our local radio station has anywhere from 10 to 20,000 daily listeners, so we anticipate that our number fell between that range. And so what are some key takeaways? It's obviously very important to know your audience and tailor your messages accordingly. It's very important to collaborate with people and have a multi-level engagement. And then, very important to really ingrain in young healthcare trainees the importance of early onset colorectal cancer screening and potential symptoms of CRC. And then we not only engage our UTHealth community, but our local community as well. And then, obviously, as we move forward, building a professional network that is dedicated to addressing early onset colorectal cancer would be incredible. And where do we go from here? And so this is definitely something that we want to continue doing at our own institution. And I think something that can be easily replicated at other institutions as well. We want to continue our focus on early onset colorectal cancer awareness. And what we're hoping to do this year is to include underrepresented communities as well, while keeping the focus on early onset colorectal cancer. That is all I have. Thank you so much for listening.
Thank you. It's hard to follow that talk. Good morning. Thank you so much for having me to talk about. Just wanted to give an overview of some of the recent advances in management of patients with cancer and also their survivorship. So we'll try to go pretty high level. I wanted to talk about the topic that Dr. Murphy had already talked about, advances in our understanding of young onset disease on a molecular level and how that's really contributed to our advancement of personalized medicine. I wanted to touch on something that's new about treating metastatic disease. Unfortunately, many of our young patients do present with metastatic disease. And then some of the newer thoughts in local therapy and with ideas about how to address the whole person and focusing on survivorship. So for personalized medicine, I think the three topics that I'll be talking about is really germline testing, tumor genomic profiling, and then circulating tumor elements. So we all know that when you look at the young onset population overall, about 1/5 of them may have a hereditary component. It's not the majority, but that is the segment that we actually know what to do about. And so just as the messages you just heard about knowing family history and implementing existing guidelines, I think the message here is don't miss any of the people that may have a hereditary component. And so there are many efforts out there now as the germline testing has become more available to implement potentially universal germline testing in this patient population just based on age. And the goal here is to catch the major hereditary cancer syndromes that we know about, which in my head I divide them to the polyposis syndromes and the non-polyposis ones. And we've all heard about FAP, which is a classic one, but there's other variants where the polyp burden may be less dramatic, and so we want to make sure we don't miss those patients. And Lynch syndrome is the most common hereditary predisposition condition. I think in the next category are the tumor genomic testing tests that have emerged. We all know today that as we get diagnosed with colorectal cancer, particularly in the metastatic and stage 3 or 4 setting, we can't go very far without one of our providers wanting to sequence our tumor. And so I think the good thing is that tumor sequencing is becoming very available. But as we all know also that the young onset tumors really are not that different on a genomic level compared to the older tumors. I think the one significant difference is that the proportion of microsatellite unstable tumors are much higher in the young patients. And so again, we want to make sure that we don't miss that population. We're fortunate in that targeting and knowing what to do with DNA mismatch repair tumors is really well known now, and we have trials using immunotherapy in all the settings, in the metastatic setting, in the adjuvant setting, so post-surgical, in the preoperative neoadjuvant setting, and even in the preventive setting. And so I think it's just, once one person is diagnosed with a DNA mismatch repair deficient tumor, to make sure that they have access to all the available therapies and some of the new trials. And I think I don't need to belabor all the details, but I think we all know how significant the emergence of immunotherapy has changed the treatment and also the outcomes of these patients. In the adjuvant setting, the question has really become who really needs more chemotherapy after a big surgery. And so we have some data years ago from the National Cancer Database to show that when a young person presents after colon cancer resection, they do face some risk of being overtreated. So I think there's a tendency for both the patient and the providers to have this fear that if I don't get more chemotherapy after surgery, maybe I'm somehow mitigating my chances of having better long-term outcomes. And so the new tool that's emerged to help decide that is really circulating tumor DNA. And so that's a test that in theory detects mutated tumor fragments in the circulation. And when we measure it in the post-operative setting, which is a time that we're calling minimal residual disease setting, so that's a time point in theory that we have the least amount of tumor in our body. So if we measure the liquid circulating tumor DNA at that time point, it supposedly correlates really well to long-term outcomes. And so there are a lot of trials now to use circulating tumor DNA measured at the MRD time point to guide further therapy in terms of deciding, am I really going to benefit from additional adjuvant therapy? And so I think that's going to help really personalize that aspect and really help us tailor risk to benefit. So again, unfortunately, about 2/3 of the patients with young onset disease already present with stage 3 or 4 disease, and so we see a lot of metastatic patients. I think the question in the metastatic setting when a person presents is always, how do you sequence the treatments? They have the metastatic burden, they have the primary tumor. Some of them may be symptomatic from the primary tumor, others may be completely asymptomatic and presented in a very silent manner. And so historically one of the debates is, do we need to take the person to surgery and take out the primary tumor up front, or do we just put them on chemotherapy? And fortunately, there's been two very recent trials, large scale, that's really helped answer that question. And so when they've randomized patients to upfront surgical resection of the primary tumor versus upfront systemic therapy, it's really upfront taking someone to surgery right away to take out their primary tumor show no survival benefit. And it actually does risk some morbidities in the surgical setting and also risk kind of derating the patients away from ever being able to get systemic therapy. So unless the patient is really symptomatic and unless there's really no other way to palliate the symptoms, we really are shying away from upfront primary tumor surgery. So that's actually been a great example of clinical trials really answer a very practical question for us. There's a lot of patients in this age group that present with a primary rectal cancer and liver metastases. And so advances in both surgery for the primary tumor, surgery for liver treatments, and also systemic therapy have worked hand in hand to really improve their outcomes. And so many institutions, including ours, have developed this treatment sequence where we address the metastatic burden in the liver first. And then we'll pivot our attention to deal with the rectal cancer after the metastatic burden has been cleared. And so that's really been a sequence that's afforded really, I think, fairly promising outcome for our patients. In the recent decades, the stage 4 patients treated in that setting has exceeded 50% in terms of 5-year survival. So again, I think for the young patients, really having access to kind of coordinated and optimally coordinated multidisciplinary care for these patients. So I'll touch quickly on local therapy. We all know the surgery quite often has been the backbone for optimal local control for patients. And when patients are diagnosed with cancer, they want surgery yesterday. And so when we measure the quality of surgery, we look at proximal distal margins, we look at radial margins, making sure that whatever other organ that the tumor is touching has been resected in an en bloc fashion. We also want to make sure that all the lymph nodes of the region has been resected. But all of that, quote unquote, radical surgery does translate to consequences in terms of function. So we know that the more extensive surgery we do, patients take a toll in terms of their functional outcomes. Particularly in the setting of rectal cancer surgery, they do take a hit in terms of restrictions on social activity, housework, recreation, relationships, and just daily, things that we take for granted. And so there's been a lot of attention paid to low anterior resection syndrome, which is a functional sequela of pelvic surgery, particularly rectal cancer surgery, which our patients are really faced with. And some of the consequences are frequency, urgency, being tied to the bathroom for half of a day, and then thereby feeling unsatisfied with their own kind of bodily function, their body image, and then relationships and social functioning. So with that, there's been a lot of efforts, and the question has been raised on, can we really downsize surgery? Can we downsize the surgery, and can we downsize the impact of surgery on patients' lives? And so I think the two approaches have been, can we downsize surgery to a local excision of rectal cancer, so simply going in through the anus to cut out the disc of the wall where the rectal tumor is. And of course, the downside is that we're not addressing the lymph node in the area, and so the trade-off then is, let's give the patients radiation and chemotherapy to supposedly treat the other disease that's in the surrounding region, and to clear that, so that we can downsize the cutting part of the multi-modality therapy. And so there's been some trials addressing that, and I think, they've shown safety data in terms of relatively acceptable and good relapse-free survival outcomes in the short term. Obviously, we're awaiting long-term results, but at least this is one of the approaches of preserving surgery-related functional sequelae. The other big topic is obviously organ preservation and non-operative management, particularly for rectal cancer. I think the term that I prefer to use is watch and wait, because quite often it's a longitudinal process, not a one-time point decision. So with new tools of MRI and additional imaging modalities, we're able to really understand that rectal cancer is very heterogeneous, and there's high-risk disease, there's low-risk disease, and there's opportunities to tailor our treatments to that so that we don't commit every patient to the same degree of toxicities related to the treatments. We don't need to look at the details of this, but there's a lot of effort in modulating what are the components of the treatment that we can give a patient prior to surgery so that we can, A, maximize chances of the entire tumor melting away, or B, maximizing the response so that perhaps we can decrease the magnitude of surgery. So watch and wait has emerged, and I think the big question there is, how can we be sure that there's no tumor left? But I put on this slide a summary of the tools that we have available today to help us determine that. It starts as simple as the digital rectal exam, but certainly imaging, endoscopy, and some of the molecular tests. But at the end of the day, we are now offering patients in whom they're exhibiting a clinical complete response to simply being followed over time. And I'll get to kind of the survivorship issue with that approach, but I think it's very welcomed by many younger patients. So moving on to kind of the last aspect, there are tasks of cancer survivorship care that's been well defined by the NCCN. And these are really the four components: surveillance for cancer recurrence, management of treatment-related consequences, prevention of secondary cancer, and coordination of care. And I think these are really four major tasks for our young patients. In terms of watch and wait, I think these issues really come to light. I put on this table down here some of the key components, I think, of survivorship care that we need to talk about with our patients as they go through treatment. Not only do they have a lot of feelings about their experience, but I think issues like financial problems, distress over recurrence, family-related issues, and also their appearance are key components. And I think we as healthcare providers should really bring these to the table even on day one, even as we are trying to put a package together to manage their tumor. Some of these issues really surface as we put patients on this watch and wait pathway, because they're really trading kind of putting off surgery to repeated, I think, stress when they come back every 3 or 4 months for their assessment, and also potential financial problems when we're committing their insurance plans to being able to afford these continuing surveillance tests. So I think these are just issues to think about when we treat the person as a whole person. We, as well as many other institutions now across the country, have developed early onset colorectal cancer programs. And similar to the prior speaker, I think when one institution is able to build a program, I think it would be great to showcase, and then so that hopefully this can be replicated across the country. And this is happening already for clinical programs. We're really happy to see that. But the goal is really to coalesce the resources, the local resources, so that we can provide wraparound care for our young patients. And so these are some of the supportive services that we're able to bring together for a particular patient that walks in the door. And we have some systematic things such as bundled order sets and patient navigation to help kind of operationalize these ideas. So for the sake of time, I'm going to finish by just highlighting that I think there's been great advances in the care of young patients. There's an expanding role of molecular diagnostics in all settings, and hopefully they'll allow us to provide more personalized and more precise treatments so that we can really tailor treatment to the benefit so that we can minimize toxicities, which is really important for these younger patients as they go on. We've made continued progress in metastatic disease. In the local setting, we're really negotiating trade-offs. We're trading off potentially the toxicities of chemotherapy, radiation with sequelae of surgery, and vice versa. So, it becomes kind of a personal decision for the patients. What is it that they're willing to take on? What is it they really want to avoid? And then at the end, I think everything factors into survivorship, and having a longer look and a whole person look for the patients is really important for this group. So thank you so much for your attention.